Dr. Ritchie, obviously he is the founder of the Ritchie Brace. He has authored over 50 articles in various foot and ankle medical journals. He is a 2-time recipient of the American Podiatric Medical Association Research Award. He has also received the Richard Schuster Biomechanics Award from the APMA. He is certified by the American Board of Foot and Ankle Surgery, and he is a fellow of Afos, and he is also a fellow and past president of the American Academy of Podiatric Sports Medicine. And tonight, like Ann said, Dr. Ritchie is going to be giving us some more details on how you can get started with an AFO program, preferably the Ritchie Brace, or restart a program. So keeping your AFOs in-house. And then we're also going to discuss how you can stay kind of safe within the bounds of just prescribing DME. So Dr. Ritchie, we're going to let you take it away.
Okay, well, thank you very much. It's a pleasure to be back and presenting the second webinar in this series for this year. I chose this webinar mainly because I continue to be amazed, not specific to the Ritchie Brace, but in general, how many of my colleagues still today do not implement AFO treatments in their clinical practice. And if they don't, I'm also surprised how many of them refer patients to other providers to have that essential treatment provided. So I'm going to take you through 5 reasons why, if you're one of those, you shouldn't really do that. So I want you first and foremost to realize that AFO therapy is good for the patient. And in spite of everything else, including the revenue, what we're here to do is try to improve patient outcomes and improve the lives of patients. And as I'm going to show you tonight with a couple of case histories, indeed, that's what we can do. If you attended my webinar in January that Sarah mentioned, it is on tape and available for you to view on the podiatrymeetings.com website. I talked about 7 or 8 quality research studies that are published in the medical literature showing that the majority of patients treated with AFO braces with adult-acquired flat foot can be successfully treated and avoid surgery. And in those studies, we see over 60% of patients in stage 2 adult-acquired flat foot will avoid surgery and can discontinue their brace and stay healthy anywhere from 2 to 10 years afterward. So that's an impressive outcome, and one of many reasons why we believe these braces help people. So the second reason is you're trained to do this. This is what baffles me. You've received excellent training to evaluate the lower extremity and diagnose the pathology. Why not show this skill to the patient in implementing biomechanical interventions to actually solve the problem? The skilled foot and ankle specialist, whether they're a podiatrist, an orthotist, a pedorthist, an orthopedic surgeon, if they're going to be skilled in foot and ankle pathology, they have to know the anatomy of the lower extremity better than anybody else. They must understand gait and muscle function. They have to be able to take a history. They have to perform an examination and come up with an accurate diagnosis. But most important, they have to take all that information and provide comprehensive care of all foot and ankle conditions. Comprehensive care involves immediate hands-on treatment. It involves patient education for their own home intervention and treatment. It certainly should involve biomechanical interventions, and it can, and depending on the specialty, involve surgical treatment. To decide you're only going to do one of those factors, to me, is shortchanging the patient and really shortcutting extensive training you have had to obtain your medical license. For example, as we showed in the previous webinar, you really need to understand muscle function, particularly in adult-acquired flat foot, the unique feature of the tibialis posterior that actually contracts twice during the stance phase of gait. And the most important part of the contraction is during heel rise or toe off. And that's when AFO bracing comes into play the most. If we can realign the hindfoot just prior to heel rise, as we see here with the Ritchie brace, we have accomplished something dramatic for this patient that we should be able to observe with gait analysis. We should know how to take measurements, and when we take measurements and perform a biomechanical exam, it shows the patient that we know what we're doing. And these measurements are not only critical for surgery, but they're critical for prescription writing for AFO devices. We need to be involved in all aspects of AFO treatment, including casting and scanning. With the advent of scanning, we don't just turn it over to our assistant. We will position the patient properly and actively participate, and the patient knows that we're involved in this, and the patient gives us credit for this. Don't forget that biomechanical interventions generally are fun to do because they work. They're relatively easy to do, and they're relatively low stress compared to surgery. Surgery may be glamorous, but anybody who's done surgery for many years, as I have, realizes there's a lot of stress with surgery, not only with the performance of the surgical procedure, but dealing with complications afterward. We also always looked at surgery as being the one area where we were vulnerable to malpractice suits. But recently, insight into this was provided in a publication from the Journal of Foot and Ankle Surgery, showing in a retrospective review of all foot and ankle malpractice claims over a 10-year period, that most of the malpractice claims actually involve non-operative treatment. And that's a surprise. We think that most lawsuits come from bad surgery, but now we find out that it's the non-operative treatment that may actually lead to failure, where the patient ends up having to have surgery, and they blame the original non-operative treatment for forcing them to have surgery. A very interesting insight. The authors concluded it's actually counterintuitive, as most surgeons would consider operative intervention to have more risks and complications that would result in lawsuits. Many foot and ankle surgeries are elective in nature, and a course of non-operative treatment is frequently the first line of treatment. It's imperative that patients are counseled on possible failure of non-operative treatment. Patients who are not counseled on this may be upset and angry when surgery is ultimately recommended. So not only is proper communication necessary, but the utmost skill and diligence has to be applied in the non-operative treatment before we undertake surgical intervention. I wrote a blog about that study just last month in Podiatry Today. And in that, I brought up the fact that when colleagues of mine refer patients out for AFO treatment instead of doing it themselves, to me, they're basically saying this, quote, "I'm going to refer you to somebody else for further treatment, but come back here if you need surgery." Basically, those practitioners are saying goodbye for now, but if you fail with the non-operative treatment, I'm here for you. That actually could backfire, as that malpractice claim study has shown. When I finished my residency in 1980, biomechanics and foot orthotic therapy were the mainstay of podiatric practice. Podiatrists never referred patients out for foot orthotic treatment. Podiatrists never provided AFO devices and rarely prescribed or referred patients out for that treatment. That's how much things have changed over the past 40 years. Podiatrists rarely got referrals for complex foot and ankle conditions or neurologic conditions to treat non-operatively, but today that's becoming a relatively standard practice. So a lot of good things were going on in 1980, and a lot of better things are going on today. But the one thing is, we didn't refer patients out for biomechanical treatments. We did them ourselves. Why would you refer a patient out with adult-acquired flat foot when your chance of succeeding is 60 to 70% with non-operative treatment? When your patient succeeds, you are the hero, not to the referring clinician. When treatment fails, you have hopefully built trust over many patient visits, such that if you undertake surgery, that patient has a much better trust in you because you've been with them from the very beginning. So number 5 of all of our reasons to start AFO bracing to your practice is you are the hero when the brace changes a patient's life. This is really tied into number 1, that it's good for the patient. This is a patient in his late 40s with a severe deformity acquired from a severe syndesmotic ankle sprain when he was in his teenage years that went on to advanced degenerative arthritis. Instead of having an ankle fusion, I dispensed the Ritchie brace with a lateral arch suspender to decompress his ankle joint. And after he received that brace, he was able to start an active lifestyle. He sent me this picture with this note celebrating his son's graduation from Arizona State University, when the morning of graduation, he and his son climbed Camelback Mountain in Phoenix, Arizona. Most people would never think a patient with that bad of an ankle could accomplish that, but he did that, and he gave me the credit for it. Nothing could be more gratifying in clinical practice to get something like this from your own patient. And finally, the fifth reason is biomechanical interventions with AFO bracing pays better than surgery. And we're going to get to that in part 2 of this webinar. How do we implement Ritchie braces, particularly in podiatric practice? Well, I just want to give you a brief history. The Ritchie brace was introduced in 1996 to the podiatric community. And at that time, virtually no podiatrists implemented AFO braces themselves. But we made it easy for them by making it a very simple modified version of the way we cast and prescribe custom foot orthotics. I enlisted over 20 certified foot orthotic labs to educate podiatrists on how to cast for AFOs and how to specifically prescribe the Ritchie brace. Since that time, we have fabricated well over 100,000 braces across the country. And today, at least 40% of podiatric physicians actively prescribe Ritchie braces or other AFO devices. We've learned that modifying or revising these braces actually has a lower rate than simple custom foot orthotics. Our labs who make foot orthotics continue to report to us that they have less problems with the Ritchie brace than they do with custom foot orthotics. What was it that made the Ritchie brace revolutionize podiatric practice back in 1996? It was basically that it was easy to cast for, easy to bill for, and most importantly, it worked for the patient. This is the catalog we published about 10 years ago, and it shows the evolving patient base that we developed the Ritchie brace for. Originally, it was a sports brace designed for lateral ankle instability for the younger patient. But it evolved as practitioners gradually found it even worked better for the patient on the inset, the middle-aged to elderly female with either degenerative arthritis of the ankle or posterior tibial tendon dysfunction. It's amazing to look at the disparity of the patient descriptions here and the pathologies that can be treated with one single brace or modifications of that brace. As I said, you will have the opportunity with these braces to produce some of the most gratifying treatment outcomes of your career. Consider this patient who has a combination of stage 3 adult-acquired flat foot combined with a drop foot after a sciatic nerve injury from a lumbar laminectomy, a complete collapsing, subluxing foot that up until her brace significantly disabled her. However, with the Ritchie brace with a medial arch suspender, it controls her drop foot and reestablishes the alignment of the foot so that she can go for a 3-mile walk every morning as she did the day I took this video. It restores almost a normal gait pattern and a normal exercise program for someone who is otherwise healthy. Consider this case of a 29-year-old retired military personnel who, while in the military, was struck by an automobile and dislocated his knee. He suffered a common peroneal nerve injury with a knee dislocation, leaving him with a drop foot. When he wears his knee brace, he can't wear a comfortable, solid AFO that was prescribed by the military dispensary. He was looking for a shorter AFO to control the drop foot. And indeed, we made him the Ritchie Dynamic Assist brace, which doesn't get in the way of the knee brace, and it completely restores a normal gait pattern and eliminates the drop foot. When we see these kinds of results in clinical practice, nothing can be more gratifying for us and it's even more gratifying for the patient when it restores an active, healthy lifestyle. So basically, in order to implement AFO braces in your clinical practice, you should understand the clinical indications. You should know what to look for in the patient evaluation. You need to understand how you cast or scan for the brace. And then most importantly, well, not the most important, but it's nice to know that you need to know how to get paid for your services. We're here to help you with all four of those criteria. The clinical indications for the Ritchie brace are wide and varied. And instead of us giving you a list of diagnoses, I like to tell a doctor or clinician, these are the clinical indications, or really the biomechanical findings that trigger you to consider AFO bracing. Because AFO bracing can be used to limit motion of a joint when we have chronic ankle instability, degenerative arthritis, or of the ankle or subtalar joint. But instead of limiting motion of a joint, some of our braces can restore motion of a joint. For example, in a drop foot condition where we can restore dorsiflexion during the swing phase of gait. We can also use braces to decrease load on injured soft tissue structures. I showed in the previous webinar how we do this very effectively for posterior tibial tendon dysfunction. In future webinars, I want to show you how we can use bracing to offload the peroneal tendons, the lateral ankle ligaments, and other soft tissue structures of the foot and ankle. We can also use bracing to offload the plantar surface of the foot in Charcot arthropathy, neuropathic ulceration, Charcot-Marie tooth. And for the athlete who suffered an ankle sprain and has lost balance and proprioception, prophylactic ankle bracing can be extremely effective, with good science backing up that notion. Our website is full of educational tools to help the clinician, even the first-time clinician never familiar with the Ritchie brace, to look at a patient and go to our treatment guide and try to select the best brace for their patient. Among those braces are the Richie Standard. This was the first brace that I developed back in 1996. It's an articulated hinged AFO. And later we added this enhancement called the arch suspender to add additional midfoot control over the midfoot joints, not only for posterior tib dysfunction, but to decompress the ankle for degenerative arthritis or control varus or valgus instability. As I will show you later, these braces are reimbursed handsomely. In most cases, $900 to $1,100 per brace. About 5 years into it, we introduced the Ritchie Dynamic Assist brace for passive drop foot deformity. This has become one of our most popular braces. It's a low articulated AFO with remarkable ability to control drop foot during the swing phase of gait and preserve normal dorsiflexion during the loading and mid-stance phase of gait. It's one of our most handsomely reimbursed braces at over $1,200. We came out with an off-the-shelf version called the OTC Dynamic Assist brace, which can be prescribed on the spot by the clinician in the office setting. Gauntlet braces are very popular in this country, and we developed a unique version, the Ritchie Gauntlet, that incorporates our patented arch suspender for additional medial lateral control over the talonavicular joint or the calcaneocuboid joint. We added a version called the California AFO that eliminated shoelaces. It's an entire one-strap closure system for patients with arthritis of their hands and difficulty tying shoelaces. We also offer a standard solid AFO, and we offer several off-the-shelf prefabricated ankle braces for immediate on-the-spot treatment. Further information about all these braces can be found on the Ritchie Brace website, and more importantly, through our authorized laboratory distributors. These distributors can be contacted by going to the Ritchie Brace website on the distributor order page. Click on any of the distributors to learn more about their company and their contact information. All of them have client service teams that have been well trained by me in order to answer the common questions about clinical indications and billing for the Ritchie brace. What are the critical steps here when we implement AFO therapy? As I mentioned, we have to be able to identify the condition. We must perform a detailed biomechanical exam. Through these webinars, as I did previously with adult acquired flat foot, I will show you how to identify certain conditions and certainly how to perform a proper examination to come up with the proper prescription. Today, I want to briefly go over the casting procedure for the Ritchie brace because we've made it very easy, and it's something that any clinician who knows how to cast for custom foot orthotics should know how to do for a custom Ritchie brace. Our website has an entire page and section on casting and scanning for the Ritchie brace with multiple resources. We have videos starting with plaster casting for the Ritchie brace, another video using the Sts Fiberglass Casting Sock. I have multiple videos showing how to properly position and use the iPad structure sensor scanner for the Ritchie brace. I have tutorial videos about the nuances of digital casting and digital scanning. But I want to just take you through the simple plaster process because that really was the initial way we casted for the Ritchie brace. We simply modified the way we take a slipper cast for custom foot orthotics, and we added one additional step, and that's an extra strip of plaster that extends above the malleoli. We also learned that we must properly place the ankle joint axis of our hinge joints of the Ritchie brace to match the anatomic hinge peculiar to that patient. Every patient's ankle joint axis is angulated from the sagittal plane and the frontal plane slightly different. Research has shown that it's identified by the tips of the malleoli. Everybody's malleoli are aligned slightly different, and every Ritchie brace is accurately matched to the alignment of the malleoli, both in the transverse and frontal plane. And this is identified by us marking the ankle joint axis for each and every patient. So we have the practitioner mark the tip of the lateral malleolus and the medial malleolus, and that's where we place the ankle joint hinges on the Ritchie brace. We start with one strip of plaster just above the malleoli, and then after that we fabricate, or we simply follow the normal steps for a slipper cast with two more strips of plaster. We recommend a neutral suspension cast for the Ritchie brace, just as you have always done for root-style custom functional foot orthoses. By doing a neutral suspension non-weight-bearing cast, we can accurately capture the contours of the calcaneus and the plantar arches, the plantar contours, and the arch configuration of the foot. Here's another sequence showing the first strip of plaster above the malleoli, completing the slipper cast and suspending the foot, subtalar neutral, mid-tarsal joint locked. And as I've talked in my previous lecture, I always recommend gentle downward pressure on the head of the first metatarsal to plantar flex the first metatarsal and reduce any forefoot supinatus. We want to maximally evert the forefoot on the rear foot, keeping the subtalar joint in neutral position. If we do not correct forefoot supinatus, as you see in the left-hand picture, we will end up with a Ritchie brace that does not fit the foot and does not control the foot. If we correct forefoot supinatus in that same patient in the right-hand picture, we get a totally different outcome. We get a positive outcome, a much better fitting brace and a much more controlling brace. When we correct supinatus in the right-hand picture, we correct the alignment of the foot naturally, and the lab does not have to correct it. In the left-hand cast, the lab has to do all the work, and in many cases, it's guesswork. The corrected supinatus cast actually creates a higher arch, but believe it or not, the arch feels comfortable. The arch is more controlling, and the patient is more comfortable in the brace than they are in the uncorrected supinatus cast. So by following the proper instructions, we get a better fitting brace and a better patient outcome. And these instructions are very important to us, such that we have devoted so much time to developing educational materials on the Ritchie Brace website. With the advent of fiberglass casting, we follow the same principles where we mark the medial and lateral malleolus, but we have to transfer those marks to the fiberglass material, because we put a plastic bag over the foot and ankle before putting the fiberglass sock on. The marking pen, the ink will not transfer directly, and I'll take you through this. The Sts Casting Sock has made it a lot easier for practitioners to cast for the Ritchie brace because it's quick, easy, and it doesn't make a mess. It's a simple kit, which is provided to you by our Ritchie Brace Lab distributors. You place a cutting strip and a cutting tube over the anterior aspect of the leg and ankle. You place a plastic baggie over the patient's foot and ankle. And then you start to roll the STS sock on from distal to proximal. You position the foot in subtalar neutral, push down on the first ray, and you wait until the fiberglass hardens. You then mark the outside of the cast at the tip of the malleolus by simply palpating the bone contour underneath the thin coat of fiberglass. It's very easy with palpation to find the tip of the malleolus and mark it with a marking pen on the outside of the cast. We then cut the fiberglass cast off with a pair of scissors. This is all provided in the kit. And we simply slip the brace off, the cast off. And we've got this beautiful three-dimensional model of the foot and ankle ready to ship to the lab for fabrication of a custom Ritchie brace. We use what's called the mid-leg casting sock when we're casting for a gauntlet style brace or a solid AFO brace. In most cases, the shorter ankle STS sock will be used for standard Ritchie brace and dynamic assist. The mid-leg sock will be used for our gauntlet braces. Scanning is certainly something that we now prefer for all practitioners because it is even less labor intensive, but it doesn't take away the need for proper positioning. The doctor or the clinician must position the patient following the same rules: subtalar neutral, mid-tarsal joint fully pronated, first ray plantar flexed. And in this case, we recommend scanning the patient in a prone position so that we can capture that anatomy on the posterior aspect of the leg and the malleoli, and we can identify where the tips of the malleoli are to place our anatomic ankle joint hinge axis. We can't take a scan of the foot hanging in space. It will capture a very supinated forefoot, and it will create a very uncomfortable Ritchie brace. We have to pronate the forefoot on the rear foot, correct the alignment of the forefoot to the rear foot, and this scan will produce a very comfortable and effective Ritchie brace. So proper positioning by the clinician with the patient prone will allow the assistant to take the scan using the iPad or now, in some cases, the iPhone scanner. Once it gets to the lab follows the same principles of balancing that cast to a vertical rear foot position. We follow the same principles we use for custom foot orthotics by placing forefoot balancing platforms and correcting the cast to bring the rear foot to a neutral or perpendicular alignment to the supportive surface. We preserve the shape of the foot plantarly. We don't fill the plantar arch or the plantar shape of the calcaneus. We want to preserve that natural contour so that the brace contours intimately to the calcaneus and the plantar arch of the foot. That's why we don't like weight-bearing casts. We want that intimate contour to the arch, the calcaneus, and the metatarsal heads. Once that cast has been modified and corrected, we press the brace onto the cast. If the cast fit the foot properly in the first place, the brace will fit the foot properly. Depending on the patient's anatomy and pathology, If the brace fits the ankle and fits the foot, the brace will fit in the shoe. Not all patients have swollen edematous ankles. The Ritchie brace can fit in dress shoes for some patients. This was a woman who wore the Ritchie brace in an 1.5-inch pump. But she didn't have a lot of pathology, a lot of edema, a lot of distortion of anatomy. Patients with adult-acquired flat foot are not able to wear pumps or dress shoes. They wear the Ritchie brace in motion control athletic shoes that have deep heel counters, removable insoles, and motion control features in the midfoot or in the midsole of the shoe to further augment the efficacy of the brace. So basically, we want to come back to the fact that the Ritchie brace is something that can be very profitable in the clinician's practice. It is a fact that AFO bracing pays better than surgery with less stress and more satisfaction for you and the patient. And why my fellow clinicians do not recognize this is actually beyond comprehension. I actually wrote a blog about this late last year titled "Surgery Can Be Fun, but Orthotics Will Pay Your Bills. Why are you referring those patients out?" I accessed a very reputable guide for RVUs, or relative value units, of common rear foot surgical procedures performed by foot and ankle surgeons. And I picked, for example, the common surgeries that are done for adult-acquired flat foot. I list here the codes, the RV units, and the general payment based on the entire geography of the United States based upon region. I picked the average amount paid for a flexor digitorum longus tendon transfer, Achilles tendon repair, cotton osteotomy, calcaneal osteotomy, and the highest pain would be the triple arthrodesis. At the most, the highest surgical procedure is the triple arthrodesis is $962, and the very common calcaneal osteotomy or cotton osteotomy are in the realm of $600 to $700. The average Ritchie brace, particularly treating adult-acquired flat foot, reimburses for $1,000. So why do surgeons seem to think that AFO treatment is not profitable and that what they're doing in the operating room is more profitable for them? It just makes no sense at all. Most AFO braces pay more than any complex rear foot surgical procedure. Now, you must realize, though, that when we look at total profit, there are other factors that come into play other than the gross reimbursement for the actual item. Understand, for example, that, and many of you know this, and I know this, I was a surgeon for 38 years, you don't always get paid the same from every payer. That $900 for a triple arthrodesis might vary significantly depending on the insurance plan and the contract you have. And some of these procedures will sometimes pay 50% of what Medicare allows. AFOs tend to be very consistent, whether it's Medicare, PPO insurance, or workers' comp. I always found that AFOs were reimbursed very close to what Medicare reimburses, and in the case of the Ritchie brace, around $1,000. The provider of the AFO has to pay the lab for the Ritchie brace, and the cost of the Ritchie brace to the provider is about $300. So the net profit for a Ritchie brace after paying the lab is about $700. When you look at the surgeon, yes, they might receive $900 to $1,000, but what they have to stop and recognize is they have to treat that patient 90 days afterward for free. There's a 90-day follow-up for most of these complex foot and ankle procedures with at least 4 postoperative visits and x-rays that you don't get paid for. You are losing a minimum of $700 when you are treating these patients for 90 days for free with considerable office time, with the dressing change, with the patient evaluation, with answering all the questions, and God forbid, dealing with potential complications. But you're also not paid for driving to and from the hospital or surgery center, and you're not paid when you get delayed in your surgery and have to wait around. Performing surgery is not time effective because of the time we waste driving there, waiting, driving home, and doing all the charting necessary. So before I go on to Medicare regulations, I'm going to just take a quick break and see if there's any questions. If Sarah or Ann want to field any questions, I thought I would take this time now, and then we're going to go into the more mundane Medicare compliance issues.
All right, let's see what we got. We do have some questions that popped up. Okay, from Charles Perry. This is the first one that was asked. Due to same and similar, it has been suggested we go straight to the custom brace, bypassing the off-the-shelf brace. Are there any Medicare rules that prevent this, i.e. you must do the cheap off-the-shelf first?
No, they're not. And I'm going to explain same and similar in great detail, Charles, in just a minute. I'm really glad you raised that. And it shows a real confusion that we all have about same and similar. So thanks for bringing it up. But to answer your question, the answer is no.
Sarah, you want to do the next one?
I can, sure. We can just go every other. What about a patient that has no deformity, negative x-rays, but simple ankle, STJ, or midfoot pain?
Well, that's interesting. You know, you're getting into what I'm about to get into. If they have simple pain, they do not qualify for an AFO, even custom or off the shelf. They have to have deformity or an actual pathology. Documenting pain only without a pathology will not qualify the patient for an ankle foot orthosis.
All right, my table won't go flat. Can I have the patient kneel on a chair?
Yes.
Perfect.
That was easy.
No, that's a great one. And in many cases, that's more comfortable for the patient. There are a lot of elderly patients who can't lay on their stomach because it hurts their back, or they have other, abdominal pain. So we have them kneel on a chair and they do fine.
Very good. And I don't know, do you have any, are there videos or anybody with doing it that way, or do we maybe need to create that?
Maybe we should make one. I don't think I have a video, but I'd be happy to make one. I do think you probably, in an elderly patient, may have to spot them, because they're in a little bit of a precarious position. But keep in mind, they can put one foot on the ground and kneel on the other. But if they have a bad knee, if they can't flex the knee to 90 degrees, you're going to have to put them supine. You can scan a foot and ankle supine. You just have to have a very limber assistant who can literally get under the foot and capture that posterior anatomy. And you have to raise the table up very high so that your assistant can get under that foot and shoot under it to capture the shape of the Achilles, the malleoli, and the posterior calcaneus.
Okay. What happens if you cannot plantar flex? I'm sorry. I'm going to start over. What happens if you cannot plantar flex the first metatarsal when doing your capture?
Great question. That happens. If you can't plantar flex it, that's the way it is. That's a fixed 4-foot varus, and that's fine. If that's the way it is, I would still put gentle pressure down to make sure the foot's everted to its own range of motion. But if it ends up capturing an inverted 4-foot, that's okay, because that's the way that foot is. We can't change that.
Is the ankle in plantar flexed position when casting in supine position?
Perfectly fine if you're doing an articulated AFO. We don't need the ankle at 90 degrees. If you're doing a gauntlet, if you're doing a solid AFO, we want the ankle at 90. And the practitioner is really going to have to work when they're loading that 4-foot to bring them to maximal dorsiflexion. But it can be done. It can be done with them lying prone or supine.
So this is the cost of a Ritchie AFO prefab was $450 charged by the lab, not the custom AFO. Was I overcharged?
Well, the Ritchie OTC brace, Boy, I can't quote what our current pricing is because we just had a price range. But I can verify that for you. If you could email me afterward, Sarah can give you my email contact. I'll be happy to verify that for you. That does sound high, but I don't want to go out on a limb yet.
Right. Yeah, I'll make a note to email, and so you guys can connect.
Yeah, thank you. Okay, I'm going to keep moving, but those are great questions. Let's talk about Medicare. You know, the first thing I want to say is Medicare is not equivalent to Ritchie brace. About half of our Ritchie braces that we make are ultimately provided to Medicare patients. The other half are provided to patients under the age of 65. We make a lot of Ritchie braces for workers' comp and a lot of Ritchie braces for middle-aged to younger patients. So I don't want in any way to imply that Medicare is the only way you're going to get paid for Ritchie braces. Medicare does, 50% of them are Medicare, and that's a significant amount, but I don't want people to become discouraged here. But I do want to talk about Medicare because there's a lot of confusion about it. A lot of doctors will say, well, I don't bill for DME because I don't want to go through the hassle. Well, it's really not a hassle. It was a hassle 20 years ago when we introduced the Ritchie brace. It was a paper application, and the application looked like a novel that you would get at the bookstore. It was about 30 pages long, if not longer. And now with the internet, everything is electronic, and it's easy to fill in the box. It's easy to scroll down. There's a lot of default options, and you can fill it out and work on it, and it'll save the application. You can come back and work on it the next day. So it's not near as difficult as it was 20 years ago, and even then it wasn't difficult. It takes about 30 minutes to complete the application online, maybe sooner, faster, depending on how you are filling out little questionnaires with the internet, and most people have gotten pretty good at that. You go to what's called the National Supplier Clearinghouse website, which is really Palmetto GBA. This is the link to it. And if you look here, there's a little thing here to click on. It says New Supplier Enrollment. And when you click on that, it takes you through a very excellent tutorial of what you need to do to get your DME or DMEPOS provider number. And so this is the first page. And they actually refer you to a Getting Started guide that's actually on the CMS website, which is a different website, the Medicare website. And that's worth going to. This is what it looks like. And they take you through just some basic steps and tell you what you need to do. And I just want to quickly say it may look daunting to podiatrists in particular because it's about 8 steps. But I want to quickly tell you, you don't have to do all these steps if you're a podiatrist or a physician. You don't have to do all these steps if you're a podorthist or an orthotist. These are steps for storefront hospital supply companies that provide oxygen, hospital beds, breathing apparatus, etc. But if you're a clinician, a licensed healthcare provider, you don't have to get an accreditation ahead of time. You do not have to get what's called a surety bond, which is step number 6 in this list. The main thing is you have to have an NPI number, which all of you probably have anyway. I mean, most of you have Medicare provider numbers. Then you have to take an additional step to get your DMEPOS provider number. But most of you have an NPI number, and you have to have one for each practice location. And then you go right to the enrollment application, and then you pay the fee. That's all you have to do, those 3 steps, okay? You do not have to post a surety bond. This is off the Medicare website showing that orthotists and prosthetists, podiatrists, nurse practitioners, and podorthists do not have to post a surety bond in order to get a DMEPOS provider number. You also do not have to get an accreditation ahead of time. What is the fee? 2022, it's $631. You will pretty much pay for that fee the first time you do a Ritchie brace. Being compliant with Medicare, this scares physicians. They say, I don't want to get audited and get in trouble because my charting or I didn't follow all these rules. It scares me. Well, the rules, I'll quickly tell you, are not bad rules. Being compliant with Medicare, to me, is best practices. When I learned how to be Medicare compliant in the late 90s with AFO bracing, it made my entire documentation for all of my patients better. I follow Medicare rules for documentation for all patients because they're the best practices rules in documenting and really preventing any malpractice claims or allegations that you're not really standard of care in everything you do. We've gone to great lengths to teach you how to be compliant with documentation, and we post multiple documents and teaching tools on the Ritchie Brace website. This is our billing and coding page that's full of documents teaching you and reinforcing how to be Medicare compliant. These are all the different documents you can download, and then there's even a teaching video at the bottom of the page. Among the documents and among the first question I get asked from practitioners is, what diagnosis should I use that will assure I get paid for a Ritchie brace? And I actually kind of am baffled that a doctor would ask me a question like that, because the answer back to them is, why don't you use the diagnosis that actually describes your patient's condition? I'm not trying to be facetious here. I'm basically saying, if your patient qualifies for the AFO based on Medicare guidelines, you don't have to make up a diagnosis. You should really use the most accurate and appropriate diagnosis for your patient. Medicare tells you in order for a patient to be covered for an AFO brace, whether it's prefabricated or custom, they have to need the brace for purposes of supporting a weak or deformed body member or restricting or eliminating motion in a diseased or injured part of the body. To me, Medicare is telling you or me what they're looking for in the medical necessity and diagnosis justifying that patient for an AFO. In other words, to me, they're looking for a disease or injury or a weakness or deformity. And so I tell practitioners to try to find both or try to document both. So we look for a disease or injury. In the case of posterior tibial tendon dysfunction, we use tendon rupture, foot and ankle. Weakness or deformity, well, you're allowed to use flat foot acquired. So we describe the pathology, which is the ruptured tendon, and we describe the deformity. Now that deformity can be drop foot, it can be talipes equinovarus, it can be talipes valgus, or it can be weakness. You can document hemiplegia. It's either weakness or deformity combined with a disease or injury. Now, if that still seems baffling or imposing, I did this for you. I went to the common 6 conditions that doctors over the past 30 years or 20 years have prescribed Ritchie braces, and I picked out weakness or deformity, disease or injury for you. And I said, for example, for Charcot foot, we document Charcot arthropathy as well as diabetes or diabetes Charcot joint. Well, we always use 2 diagnoses. For degenerative arthritis of the ankle or hindfoot, we use osteoarthrosis. We can also combine that with pain, but if you only use pain, as the doctor asked about earlier, that won't qualify. You must combine it with a pathology, such as osteoarthrosis, or a deformity. If the ankle has moved into severe varus or valgus, please document the deformity. And of course, your notes have to show that. If your notes and examination findings don't show it, you might be suspect if you go under a chart review. I provided you with a checklist where you can check this off prior to sitting down and entering all this in your electronic medical record. But we used to use this checklist when we billed Medicare, but Medicare doesn't accept checklists anymore. The checklist is not adequate for you to document the medical necessity. You must have a narrative report in the electronic medical record that documents weakness, deformity, pain, or injury. And I'll get back to that in a minute. Medicare requires that you provide what's called a proof of delivery, or what we call a receipt. And we provide a little sample of this, a template that you can use, and the patient signs this, that they received the brace on this day, and they received instructions on how to use it and how to fit it. They also received their 21 Medicare supplier standards. Every patient is to receive a copy of the supplier standards when they receive the durable medical goods. We provide you with the fitting instructions, and that's what the patient signs on that previous document, that they did get instructions for fitting. Here's the supplier standards that you're supposed to give to the patient when you also give them the goods. You are also to keep in your office a complaint log, and we give you templates for that. Hopefully you never have to have a patient file a complaint. You just have to have a log available in case your office does get inspected by a Medicare personnel. If all that seems daunting, I wrote a detailed document for you. You can get off of our Ritchie Brace website, and I take you through what you need to do to be compliant. And when you read this, you'll say, well, I don't mind doing that because it's just good medicine. And in there, I give you examples of what your medical record should actually look like when you decide to prescribe a Ritchie brace. And I give you sample medical record notes of what these notes should look like. It's not a template because these notes should be in your own verbiage and your own language. But what I try to do is show you what the elements of the notes need to be compliant with Medicare. For example, degenerative arthritis of the ankle. I go through some clinical findings, which I didn't show on this slide, but what the verbiage should be in almost every case is that you are going to prescribe a custom ankle foot orthosis with ankle joints. And the reason is the patient has significant pain and limitation of range of motion of the ankle joint. You've previously documented what that limitation is, by the way, in your exam findings. There is clinical evidence of equinus deformity. You're documenting the deformity here. The ankle and hindfoot demonstrate evidence of valgus deformity. The gait pattern demonstrates severe antalgic guarding, weakness of ankle joint dorsiflexion, and valgus deformity. What we always recommend adding is this phrase. This patient is ambulatory and requires stabilization of the foot and ankle due to loss of range of motion and equinus deformity. This patient has the potential to function from the prescribed ankle foot orthotic with the following treatment goals: decreased strain on the joint, correction of deformity of the foot and ankle. So those phrases are really important in the medical record because that's what Medicare looks for. Patient is ambulatory, requires stabilization, and will benefit functionally. We have it for drop foot and hemiplegia, and we have it for adult acquired flat foot. You'll also notice that we always say, if we're going to do a custom brace, we say the patient could not be fit with a prefabricated AFO. And the reason is that the deformity is such that a prefabricated device will not fit the severe valgus position of the ankle, the severe abducted position of the forefoot on the rear foot. So in the notes, you must always justify why you're going direct to a custom, not a prefab. To answer the question that was posed earlier, we don't have to go to a prefab brace for Medicare. We just have to document why you didn't go to a prefab, and in most cases, it's due to their deformity. So somebody brought up the same and similar policy. This is one of the most ludicrous and ill-founded governmental regulation I have ever run into, but I will also tell you it should not dissuade you from implementing Ritchie brace because it is very simple to work with, and it should not in any way discourage you from implementing Ritchie braces, and for sure it's not going to make you get audited and go to jail. So the same and similar policy first started out 20 years ago, simply enforcing what's known as a 5-year rule for the lifespan of AFO braces. But we have learned over the past 5 years it has become a tool to stop these telehealth scams that were flourishing 5 years ago, where they were providing 4 to 5 knee braces or spine braces to a single patient simply over one single telehealth visit. And they were billing Medicare and getting paid for 5 braces to one single patient. And Medicare shelled out millions of dollars for this and decided they needed to do something about it. And what they did, though, has backfired on us as practitioners, as I'm about to show you. Many of you have read about these Medicare fraud schemes. They almost always have involved durable medical goods and many times braces. In most cases, by the way, the braces were spine braces or knee braces. They weren't lower extremity braces. Same and similar is explained on the DME MAC websites, and they basically explain that it is twofold. It's to limit reordering of braces too soon for patients within a 5-year period, and it's also to limit the use of too many braces for the same patient. But that's where, in my mind, the rule becomes unfair. Just like everything with Medicare, I tried my best to make this simple for you, and I took a course with Meridian. I took a webinar course, and after taking the course, I immediately sat down and wrote out a 5-page document trying to simplify and then make you understand what same and similar is and how you can get through this. And it really is not difficult. The first part is dealing with wear and tear versus irreparable damage. Medicare says the typical AFO should last 5 years. Now that's a stretch, especially for some of these patients that are very overweight or very hard on their braces and on the hinges, but that's the way it is. In general, Medicare will not replace the identical brace in anything less than 5 years unless the patient's medical condition has changed. If the brace has undergone irreparable damage, Medicare will replace it, but that irreparable damage has to be, according to Medicare, loss from theft or fire, believe it or not. You literally have to show an accident report or a police report that the brace was stolen. Simple wear and tear is not considered irreparable damage. Now, if the brace breaks, that is irreparable. If the brace simply gets worn out on the top cover and the hinges, that is repairable, not irreparable. So Medicare will replace a brace if it's broken, if it's lost, stolen, or damaged in a fire or flood. But they will repair for repairs of a brace in all other cases. They have 2 specific modifiers. One for when we replace an item due to loss and irreparable damage, and that's modifier RA. And modifier RB is when we're simply refurbishing the brace. Now, if you submit a claim with modifier RA, you better also append that claim with photographs showing the damage to the brace, that it's irreparable. When you use it for a simple refurbishment, you simply describe it in the description section, but you don't necessarily have to provide photographs. Medicare is not scrutinizing repair RB codes, but they are definitely scrutinizing RA codes. We've made it very easy for you to refurbish a Ritchie brace for your patient. We're currently running this ad on PM News that Sarah designed for us, and it's a very compelling, effective ad showing that we send you a kit, which you can order from one of your labs, and you can refurbish a Ritchie brace right in front of the patient by simply, and we show this in a video, you peel away the lower limb pads to the limb uprights, and you can put new Velcro straps and new pads on. Those are the main things that wear out in less than 5 years. And you can give it right back to the patient, and you can be paid about $140 for it, which is nice. The kit costs you about $40, so you get a $100 profit. And most important, the patient walks out of the office with what looks like a brand new brace. Otherwise, you have to send the brace into our lab, and we will put new top covers on, polish the brace. We can replace the hinges, all of that is described on the Ritchie Brace website, and all of it is reimbursable by Medicare. Medicare will reimburse any of your lab charges when we refurbish a brace for you. They will pay up to the original cost of the brace for multiple refurbishments. You could refurbish a Ritchie brace 5 times in 5 years, and you will be paid for it as long as the sum total does not exceed the reimbursed value of the brace from day one, which is about $900. The real problem is when we provide an AFO to a patient who already had a previous AFO. And that's following into the other part of the same and similar policy. Medicare says that any brace that is coded with any of these L codes, if the patient gets one of those braces, they cannot get any other brace in that group in 5 years. Medicare will not pay for it. And I will tell you, in that group there is just about every brace you would ever prescribe in clinical practice treating lower extremity pathology. Any of those codes are in that category. And so what that means is if a patient has been given a plantar fascia night splint 3 years ago for plantar fasciitis and suddenly ruptures a posterior tibial tendon 3 years later, Medicare says that that plantar fascia night splint is same or similar to a Ritchie brace. They would say if a patient had a lateral ankle sprain and was treated at an urgent care center and received that figure of 8 lace-up ankle brace on the left, 3 years later, they could not get a Ritchie brace because Medicare considers that same or similar. That is grossly incorrect, grossly unfair, and it's an injustice to the patient. It's a rule that must be overturned probably by an act of Congress. And it has been attempted by many associations, and why it hasn't been overturned, I don't know. But I will say this, Medicare acknowledges that if the practitioner can show that it's for a different medical condition, they will reimburse for the new brace. If it's a different medical condition for which they had plantar fasciitis, that they now have posterior tibial tendon dysfunction, Medicare will reimburse. But in most cases, it's going to require an appeal by the doctor. The real area where we can get in trouble is fitting a walking boot. Walking boots are very commonly prescribed, but they fit under same and similar. If you decide to put a walking boot on a patient before a Ritchie brace, Medicare will pay for the walking boot, but they won't pay for the Ritchie brace because that walking boot and the Ritchie brace are presumably for the same medical condition. That answers the question I had earlier. You would be better off charging the patient cash for the walking boot, telling them, I'd rather charge you cash for this because otherwise Medicare won't pay for the $900 Ritchie brace, and you can buy the walking boot online for $40 to $50, or the practitioner can sell it to them right in the office. It's your choice. I have found that many of these conditions require a walking boot before I put them in a Ritchie brace. And the challenge is, what are you going to do? Well, you charge the patient cash for the walking boot and save the Medicare billing for the Ritchie brace. If they're workers' comp and PPO, you don't have to worry about same and similar. The form that's on the Ritchie brace website that takes you through same and similar takes you through 4 essential steps to avoid same and similar denials. You verify whether they've had a same and similar brace in the past. You document in your chart why the medical condition has changed. You empower your patient to call Medicare and say, hey, I got a brace 3 years ago for plantar fasciitis. I now ruptured my posterior tibial tendon. I want to make sure you pay for this brace ahead of time. I want you to tell me you're going to cover the brace. And believe it or not, Medicare often will tell the patient that. So I take you through the steps of how to verify. And I'm going to take you through this briefly. How to document, and you're basically going to document why you're prescribing a same and similar brace. You're going to document this patient has an off-the-shelf brace. It's not controlling their lateral ankle instability. I need to move them into a custom brace. The off-the-shelf brace wasn't working. And here's why. And it's all in my medical notes. And I'm going to document why they need a custom brace. And I'm going to bill Medicare for it. And I'm going to go to bat for my patient and appeal it if it gets denied. You have the patient ahead of time, talk with a representative of Medicare, inform them of what's about to happen, and ask them to give them feedback on whether or not they're going to cover the brace ahead of time. And often Medicare actually tells them this. And finally, I teach you how to appeal and advocate for the patient in case the same or similar denial occurs. When you verify same and similar bracing, you have to go to the DME MAC of the region where the patient lives, which may or may not be where the practitioner is, by the way. And what is really recommended is that you check at all 4 jurisdictions, because that patient may have lived in a different jurisdiction 4 years ago, and they can't remember that they got a brace when they happen to be on vacation in Florida, even though they live in California. So we recommend that you register as a provider at all 4 of the DME MAC sites. In this case, it's 2 Meridian sites or 2 CGS sites. Region A, B, C, and D are covered either by Meridian or CGS. And when you go to the Meridian site, there's what's called the Meridian Medicare portal. And that's where you're going to go to verify whether this patient has received the same and similar brace. Very easy to do. All you have to do ahead of time is register. And both Meridian and CGS make it easy for you right here to start a registration. This is not like getting a DEMA post provider number. You register for that DME MAC, and once you register, from then on, you can go into their site, enter the patient information, enter the L code of the brace you want to prescribe, and they will tell you automatically if that patient has received a same or similar brace from that region or that jurisdiction in the last 5 years. We recommend you do it for all 4 jurisdictions. It doesn't take that long. It takes less than 5 minutes, and that way you cover yourself. Here's the CGS Portal Site, very similar to the Meridian site. You do have to register, but they too have a same and similar option for you to browse and verify if there's been a previous brace dispensed. So what if they tell you, yeah, they did have a previous same or similar brace? They will tell you what year they got the brace. If it's a different brace, if it's, for example, a prefab brace, all you need to do is now document in the medical notes why you're prescribing a different brace. And it's all based on medical necessity. So in other words, is it a different brace for a different condition? The likelihood is you're going to win this appeal because you have the medical necessity. If you're about to prescribe the exact same brace the patient had 3 years ago, you're probably not going to win the appeal. You're not going to get paid, and you're probably not going to win the appeal unless you have some extenuating circumstances why the current brace isn't working and why a new brace is supposedly going to work better. But that's a hard sell. If you think that you're not going to win an appeal, if you think that this is a gray area where it's the same brace for the same condition, the odds are you're not going to get paid, and you should have the patient sign an advance beneficiary notice. Medicare gives you guidelines of what the ABN should look like. They actually give you a template that you can download. And this allows you to bill the patient directly for the DME device in order to gain reimbursement from a failed Medicare claim. If an ABN is signed by the patient, the provider must append the claim with a GA modifier. And once you put a GA modifier on, Medicare is not going to pay the claim. Not a problem, because you've already informed the patient ahead of time, I'm going to charge you for the brace. In the case where the medical condition has changed and or you're providing a new different brace, you don't necessarily need to have the patient sign an ABN if you feel confident that you can win the appeal. And in the webinar I attended, Palmetto was Meridian was very forthright in saying that if the patient has a new medical condition, you are justified in getting paid for that new brace, the new different brace. And so you don't necessarily have to have the patient sign an ABN, and you should bill it like you normally do with the KX modifier, because you believe that this brace is medically necessary for the patient. For sure, you should not routinely use an ABN for each and every patient. You should use it only in the case where you believe Medicare is going to statutorily deny the claim, and ahead of time, you're going to go ahead and tell the patient that they're going to have to pay for the brace. But in most cases, if the medical condition is changed, I would not have the patient sign an ABN. I would do my best to justify the claim from the outset and definitely be prepared to appeal if it gets denied. This is what an ABN, and I'm going to take your questions in just a minute. I'm almost done. This is what the ABN looks like. You can download it from the Medicare site. And Medicare tells you what statements are acceptable to put in that ABN. And basically you say, I believe this brace will be denied under the same or similar policy. That's the reason you're having the patient sign an ABN. Medicare says you can even say Medicare usually does not pay for this service. I think that's a little wishy-washy. I would be more specific and say Medicare will not pay for a new brace in less than 5 years, etc. Again, that's only if you're going to go ahead and tell the patient from the outset, you're paying for this brace, you got to sign the ABN. In summary, I would recommend an ABN and use the GA modifier when you're giving the same brace, same L code brace within 5 years of the same previous brace. In general, I do not recommend an ABN, and I recommend you use a GX modifier when the patient is getting a different L code brace for a new medical condition, despite the same and similar brace over the past 5 years. If it's a different L code brace with a new medical condition, you have every justification to go to bat for that patient and get Medicare to reimburse for that new brace. In the event your appeal is or your claim is denied initially, I show you on this document how to appeal and advocate, and so does Medicare. Meridian, for example, gives very specific instructions on how to go through the appeals process. It's all done online, and it's all done with your medical record, and it's all based on medical necessity, and you, the practitioner, justifying the new medical condition. The change in medical condition, along with the diagnosis, prognosis, duration, functional limitations, clinical course, the reason the past experience with the brace failed, and why you think the new brace is justified. It's all good documentation anyway. It's all important to document from the outset. So in summary, 5 reasons why you should restart AFO bracing in your practice. Most important, it's good for the patient. Don't ever forget that. You're trained to do it. Why not use your knowledge and training and show that to your patient? It's relatively fun, it's easy, and it's definitely stress-free compared to surgery. You will look like a hero, and you will feel a fulfillment when you implement these braces, much more so than you do in any other part of clinical practice. And don't forget, it pays better than surgery. And with that, I'm going to be happy to take any questions. Sorry I went over, but it was an important topic.
No, absolutely. And I can tell that everyone is, it is an important topic because nobody got offline. So everyone that started with us is still here. So, and I do want to circle back really quick. There was a question from the previous section, and I just want to, I don't know if it's equally or less or more important than coding, but it goes back to the iPad scanning, and they were wondering if there's a special program required for to be able to do the scanning.
Yeah, so these lab distributors you see on your screen, am I still sharing my screen?
Yep, you are.
They all have an app which they provide their customers, and each app is different for each lab. but it's an app that's loaded onto your iPad, and some of these labs have it actually for an iPhone. And that app will enable your scanning option with your iPad or iPhone to interface directly with the lab so that you can place the order and transmit the scan data directly to the lab. So you contact any one of these distributors and you say, I'm interested in scanning for a Ritchie brace. What do you have to help me get started? And they will tell you.
Awesome. All right, so another question. Some other suppliers state that muscle weakness or equinus, less than 15 degrees of dorsiflexion, qualify for DME bracing.
Sure. Equinus is a deformity. Less than 15 degrees is is really a physical finding. It's not a diagnosis, but I would do equinus and then also document why is there equinus. I would document either contracture of the gastroc, or I would diagnose weakness of the tibialis anterior or the ankle dorsiflexors. Again, I always come up with 2 codes and 2 findings. Equinus is only one, but absolutely, equinus is a very justified reason for AFO bracing, but you better have one other reason as well.
All right. How often should a Ritchie brace be replaced?
Well, I've had patients wear a Ritchie brace for 5 years. As I've talked in my last lecture, if I'm treating posterior tib dysfunction, I'm going to get 50% of my patients out of the brace within 5 years. A lot of the pathologies we treat are not lifetime. Drop foot, unfortunately, is lifetime. Degenerative arthritis is lifetime. I think a Ritchie brace with proper refurbishment of the pads, of the Velcro straps, and occasionally the hinges, which is done at the lab, it should last 5 years. I think you should refurbish the straps and pads every 6 months.
Okay. What if they've been using an OTC air cast brace and now need a custom Ritchie brace for PTTD and ankle degenerative disease?
Okay, so if it's been within 5 years, that'll fall under same and similar. Despite the fact that they obviously have failed with the air cast, you think and know a custom Ritchie brace is far more efficacious. You're going to now be dealing with same and similar. You're going to be dispensing a Ritchie brace, which is a different brace, but Medicare considers it same and similar. It's the same medical condition, it sounds like in this scenario, but it's the brace they're currently wearing has failed. So you feel justified in prescribing a different brace because the current brace has failed. All of this is in the medical record. I believe, and Medicare has told me, that you're justified in billing for a Ritchie brace, and I wouldn't have the patient sign an ABN with the modifier, because I would submit the claim and be prepared to appeal based on medical necessity that they need a new and better brace. If you think it's a gray zone and you just don't feel comfortable, you're always entitled to have the patient sign an ABN. An ABN is justified here because this is a situation of same and similar. And any same and similar is justified to have the patient sign an ABN. The problem is once they sign the ABN and use the GA modifier, you're not going to get paid and you can't appeal it and you have to bill the patient.
Okay, this question may be almost the same. So when brace number 1 is not working, what else can you say as to why you need a custom brace?
Yeah, so it's failing to address the medical condition. The condition is still persisting. I think it's really important to say the condition is actually worsened based on symptomatology and maybe based on deformity, and it's not adequately addressing the current medical condition. It's just really tough when you are going to prescribe an identical brace. If the patient comes in wearing a Ritchie brace and it's gotten worn out, or maybe you think the material has flattened in the foot plate and you're going to prescribe the exact same brace, that's a tough one. I think you're better off going with an ABN. But if they come in wearing a Gauntlet and you want to prescribe a Ritchie brace, I think you've got a good point here. You're going to go with a different kind of brace. Yes, it's same and similar, but it's a different brace. And based on medical necessity, you can justify why you're switching to a different brace.
Okay. We don't have any other questions sitting in the, unless there's something in the chat.
Yeah, there's a couple in the chat, so I'll switch over to that. What if a patient needs a left and a right brace?
Well, I want to quickly say real quick, same and similar is only specific for the extremity. So, and when you do your verification with the DME MAC, with the portal, it will specifically ask you which extremity you're dispensing this brace on, left or right. Because if they had a plantar fascia night splint on their left foot and they have posterior tib dysfunction on the right, you don't have to worry about same and similar. It's specific to the extremity. So, bilateral bracing, you're allowed to dispense bilateral braces if there's a pathology on each side that justifies it. I will tell you that's unusual. The vast majority of custom AFO braces dispensed in this country are unilateral. That's just the way it is. It's very rare to get bilateral drop foot. It's very rare to get bilateral posterior tib dysfunction at the same time. It's very rare to get post-traumatic arthritis of the ankle bilaterally. And so when you're constantly providing bilateral braces, it could be a red flag for an audit. But there are cases where you do it bilateral. I've done it myself many times in clinical practice. It's just as long as it's medically necessary and justified in the patient medical record.
Can you comment on the new legislation that will allow dispensing of AFOs without a DME license?
Okay. I just read that today. And by the way, that legislation hasn't passed. I just got a little bulletin from APMA asking me to write to my senator. And it's legislation that appears to be primarily pushed by our friends and colleagues in AOPA, American Orthotics and Prosthetic Association. And it's peculiar to off-the-shelf prefabricated devices, not custom devices. And it's specifically designed to try to get around these crazy competitive bidding restrictions and on devices that are not expertly fitted by the orthotist or the practitioner. I don't think there's much in that legislation that's really specific to podiatry, although I think we should support it. I did not read anything in that application that said it would enable non-licensed practitioners to dispense prefabricated AFOs. I think it actually is the contrary. It's trying to control the fitting of AFO braces by non-healthcare professionals. You have to understand that a patient can go to a medical supply store in a mall, in a strip mall, and they can get an ankle brace. They can get a prefabricated AFO. They're not going to get a Ritchie brace because we don't give them to them. We won't let them provide those. But they can get fitted for a prefabricated walking boot or a prefabricated ankle brace. And my interpretation of this new law is that that will take it out of their hands and put it back in the hands of the people who are expertly trained, and that's podorthists, orthotists, and podiatrists. So I think it's a good bill in that sense. It doesn't enable hospital supply chains to do ankle braces any more than they currently do. I think it's supposed to restrict it.
Okay.
All right, we've had a couple more pop over into the Q&A. So are they, which I'm guessing he's referring to the Ritchie brace, indicated for bilateral plantar fasciitis?
No. that would not be a diagnosis by itself. I get asked that all the time. In general, a isolated diagnosis like plantar fasciitis, or believe it or not, I've had doctors ask me if you can use it for a bunion. And it's like, AFOs or ankle foot orthoses, they're designed to support a weak or unstable, quote, foot and ankle. We really are looking at pathologies that are foot and ankle related. Now, you could be creative and say, well, I have a patient with plantar fasciitis that also has equinus, gastrocnemius contracture. But I think it's a red flag when you're using that alone. Now, we have a brace called the Aerospring that we do recommend for plantar fasciitis. It's a carbon fiber AFO, and we do combine codes for that if it's justified for equinus, gastrocnemius contracture, plantar heel pain, weakness of the anterior muscle group, etc. But we have to combine it with weakness that is documented. You have to measure restricted ankle joint dorsiflexion. Don't just make it up. And we use our Aerospring brace combined with a custom foot orthotic, and that's all on the Ritchie Brace website. But and that carbon fiber brace is designed specifically to offload the plantar fascia. A Ritchie brace is not. The Ritchie brace is designed for other pathologies, and so for various reasons, I would answer that question no, just because the Ritchie brace isn't designed for plantar heel pain.
Okay. Do you happen to know which providers, which labs do have the scanning app with the iPhone specifically?
Well, I don't want to get in trouble here, so I'm not going to say this is exclusive, but I know for a fact Kevin Root Medical has an app for an iPhone, and Comfort Fit just recently introduced their app for an iPhone.
All right. Let's see.
Awesome.
Passed in the chat. I think that looks like we covered everyone's questions.
Yeah,
All right.
that's awesome.
Awesome.
Thank you guys for sticking around with us. Obviously, you had, a great interest in this topic and lots of questions to answer. So, we're always taking feedback. We'd love to hear about what you'd like Dr. Ritchie to talk about next. So if you want to take a minute and just email us and let us know what kind of topics you'd love him to cover, we can pass that feedback along. And it takes us a few days to get this recording loaded up to the website. So if you missed a portion of it, or it was so great that you just want to watch it again, just check back later in the week and that should be up there.
All right. Very good. Yep. Again, thank you, Dr. Ritchie, for being here, for presenting a really important topic, because this is something that is so beneficial to patients and can have so much opportunity for practices like you mentioned. So I just want to reiterate that. And for anyone who hasn't started bracing, Dr. Ritchie, I'm just going to throw in one last question here for the evening. What would you recommend for anyone who has not started using the Ritchie brace? Because there could be people online who have tried the brace before, so they have an idea of how to kind of, what's the first step to really get their practice going. But obviously incorporating anything new into the day-to-day requires quite a bit of organization, from just, getting the supplies, training the staff, marketing it, and educating patients about the service that you provide. So is there any kind of last advice that you can provide any of the physicians online who have never started an AFO program with the Ritchie brace, the first step to get started?
Yes. Our website, I would reach out to our Ritchie brace website, to the consultation page. And I forget which page that's on, Sarah. You can tell them.
It's just on the contact page. So yep, there's a contact page in it. There's a consultation request, and then there's a couple different reasons to contact. So consultation is on that contact page. And
reach out to me. The bottom line is reach out to me, and I'll talk you through it, because I'll talk to you about your patient. That's most important. Tell me about your patient. I'll say, okay, I think they are a candidate. Here's what brace. And then I'll help you pick which lab to go to. Maybe it's a lab you're already using for your foot orthotics. I'll introduce you to the lab. The lab will take it from there with the order forms, the price sheet. They might give you an Sts Casting Sock and all of that. So I'm happy to walk you through it. I answer my consultations every day. I'll talk to you on the phone, but the initial reach is through a quick email form that you fill out, and you fill that out and send it to me. I will get right back to you. I'm happy to do it.
Awesome. Well, easy
Awesome.
enough. And yeah, you might as well speak it from the expert, right?
Right.
Yeah.
I
I love that you make yourself available to everybody. You know, you're not just here to push a product or anything like that. You're really here as a resource. You're just here to answer people's questions. You'll take as much time as you need, and you really created something that you believe in, and you're happy to, you know, support the industry and provide as much information as you can. So I think that's great.
Thank you.
Awesome sauce. All right, everyone. Well, thanks so much again for joining us. Don't forget, we've got another webinar coming up next week with Podiatry Content Connection, our monthly marketing tips. So check that out on our website, sign up, and we will definitely keep you posted. We are doing quarterly webinars with Dr. Ritchie. So it will blink and it'll be here.
Yeah.
I can't believe we're already in number 2. So keep your eyes peeled and your ears open for information on that. I know I'm excited about it. Dr. Ritchie has some more work to do. And we will definitely see all of you then.
All right.
Awesome. Okay.
Thanks,
Talk to you
everyone.
soon.
Sure.
Bye.